Hello, everybody. Welcome to another macular degeneration seminar. Today, we are going to talk about something I know is going to interest all of you, and that is reducing the frequency of your eye injections. I'm assuming many of you are undergoing those right now. There's a new product out. It's a port delivery system, and you're going to hear about how it works and how long it lasts. It's brand new. It's just been approved. Our speakers today will talk a little bit more about it. First is our medical director, Dr. Joshua Malley. He is a macular regeneration specialist and retina specialist. He graduated cum laude in biology from West Virginia University, where he received the prestigious WVU Foundation Outstanding Senior Award. He then continued to the West Virginia University School of Medicine for his medical degree and internship, where he was awarded a scholarship. He will be talking about, he will be leading the discussion. He will be answering questions that are going to be provided primarily to him by Dr. Jeffrey Gerson, who is a Macular Degeneration Association Medical Director for Optometry. He graduated from Indiana University School of Optometry in 1997, after which he went to do a VA residency concentrating on low vision and ocular disease. He has been in several practice settings, including a retina referred practice where he participated in several large-scale clinical trials. Dr. Gerson is a frequent lecturer in the United States and abroad and writes regularly for optometric publications. He practices at the Grin Eye Care in Kansas City, Kansas. So it's now my pleasure to turn it over to Drs. Gerson and Malley, who will participate, as I indicated.
All right. So I will just get us kind of started off here as Dr. Malley's getting on. As Larry said, this is pretty exciting to have something totally new in the world of macular degeneration. It's been probably about 15 years ago that the first injections for macular degeneration were approved, and we can see, and that dramatically changed the landscape of how people with wet AMD got treated, both as far as how they were treated and outcomes. And so then this is the first big change in 15 years or more since injections, because up until now, what everyone's been looking at is, can we come up with a better injection, or maybe space out the time in between injections some, because many people with wet macular degeneration need to get injections every 4 to 6 or maybe 8 weeks, but many people can't go longer than that. And so the whole idea is there a way to decrease the burden on you, the patient, so that you're not needing to go in and get these injections as frequently, to make your life easier, to make your lives better, hopefully with less treatments, less visits to the doctor's office, and ideally even with better outcomes. So that's kind of the whole idea that was behind this new product that's called Susvimo. Don't ask us where the name came from. I have no idea. Maybe it's Latin for something. I don't know what it is, but that's what it's called, Susvimo, Susvimo, and is made by the company Genentech, same company that makes one of the medications that gets more regularly injected. So with that, I think Dr. Malley, I think you may have 1 or 2 slides you wanted to share.
Sure. Yeah. Let's put up the anatomy slide, please. So again, thanks everybody for attending this webinar, and we're really excited to have you on here and discuss this really dynamic and innovative technology that we have now available from Genentech. But I want to kind of start everybody on the same page here and just go over some basic eye anatomy and what we're talking about. So that way everybody knows, with the different structures of the eye, knows exactly where we're discussing this, what we're talking about, where this new device goes and where in the eye that we're treating. So as everybody may know, macular degeneration affects the retina, which is the back wall of the eye. And you can see that there's on the diagram, there's a pointer showing the area of the retina, which is kind of the inside back wall of the eye. And in particular, where AMD affects is the very center part of the retina called the macula, which is also labeled there as well. And that macula part of the retina is the most important area for vision, for central vision. So this is the vision we use to read, to drive, to see our grandkids, whatever the case may be. Most important area for vision. And unfortunately, AMD is a disease that affects that part of the retina. So that's why patients develop distortion, blurry vision in the center part, and all the symptoms that go with that. Now, when we're talking about the Susvimo device, that's going to be surgically implanted really under a skin layer of the eye called the conjunctiva, which is labeled there at the bottom, which is very like a kind of a skin layer of the eye, which is in the white part of the eye. The white part of the eye is called the sclera, and that's kind of where you see the white part of the eye. That's the sclera part of the eye that we're seeing, and the port is actually going to go through that sclera into the eye, into what we call the vitreous cavity, which is also labeled there as well. So that's kind of where all our medications, whenever we do eye injections, that's the area where we inject the medication into the eye. And subsequently, this is also the same area where this port delivery system is going to be actually inserting the medication into the eye from its module. So with that, I want to make sure that everybody was on the same page in regards to anatomy, where the implant goes, and what part we're hoping to treat with that. And so now I want to kind of show you a picture of the actual device, the Susvimo device, and we'll pull up the picture of it here. We have a little image. So on the right-hand side of the screen, you can see the actual implant itself. So you can see it's kind of a cylinder-shaped implant with the area for reservoir to hold the medication, and which is called ranibizumab. Also, it's a different thing to remember. It's a different concentration of Lucentis. So it's not exactly Lucentis. It's the same molecule, but different concentration that we're using. So that's why you're seeing that concentration there, 100 milligrams per milliliter, is a different concentration than what we give in the office with an intravitreal injection of Lucentis. So it's the same molecule, though, and that's called ranibizumab. And so you can see there's the reservoir, and then it has that cylindrical body, which goes inside the eye, and then that's where it kind of releases the medication. And what they found, and you can see there, you can kind of see how it looks on the eyeball itself there with the other sort of images. And you can see there's on the white part of the eye, you see a little bluish hinted area. That's where one would do a potential refill of the implant. We'll talk about that later. But that's where in the office where we do the actual injection portion to refill it, is through that little area there. Now, from the clinical trial, what we saw was it had very good efficacy. So it was actually compared to monthly Lucentis versus this device, which was refilled every 24 weeks in the office. So compared to a monthly injection of Lucentis, it actually showed equivalent visual gains between the two, which was pretty significant. I mean, just to have potentially one injection every 6 months versus a monthly injection, they both were about the same vision wise, and it appears also to be generally very, very safe. And if we get, I think there's one more slide. Great. And so one thing to keep in mind is that about 95% of patients did not need any sort of additional treatment during the 6 months. So they didn't really need any additional injections or treatments to help to maintain those visual gains that the monthly injection people were getting. So again, overall great efficacy and very safe. So with that, I want to save enough time for us to kind of talk about some most commonly asked questions, and then of course keep a good amount of time for any questions from the audience. So with that, I'll pass it back to Dr. Gerson.
Yeah, so the idea here is that we're going to kind of go back and forth with some questions that I've prepared. But as always, what we want to do, like all of our other webinars that we do, if any of you that are tuning in have questions, I would ask for you to go ahead and type those in. And so you can send those in through the chat, and we will address any of your, or I'm sorry, the Q&A, sorry. So if you want to send those in the Q&A, then we will address any of those. So until we get those, I'm going to go through some of the questions that I have prepared for Dr. Malley and kind of start the conversation. So I guess the obvious one is this going to become the new automatic treatment for all patients with wet AMD?
Yeah, great question. So I think you always got to think of this as, as in medicine, one treatment is not for everybody, right? Any condition, there's not just one treatment or one strategy or one medical device for every single patient. Every patient is different. Every patient has different needs, requirements, things like that. So this and Susvimo itself, again, I don't think it's going to be for every single patient out there with wet AMD, but I will tell you kind of what an ideal patient that I would suspect in my practice would be, is a patient that has a history of wet AMD, that is receiving, eye injections on a frequency of every 4 to 6 weeks, has to have consistent injections every 4 to 6 weeks, that has maybe been, has the disease for about a year, 2 years or more, but has been tried to be extended out further on injections, like maybe gone up to 8 weeks or 10 weeks, but has, had a recurrence of disease. And that's why we've been keeping them around 4 to 6 weeks. So it's someone that requires really frequent injections. So 4 weeks, 5 weeks, 6 weeks, and so forth, that needs that constant treatment in order to maintain their vision where it is. That to me is probably the most ideal patient to consider this Susvimo for. So in my opinion, that's kind of the ideal patient. Not to say that other patients wouldn't be great patients, but I'm just kind of looking at a slam dunk, easy, no-brainer patient, and that to me is probably the best one. It's someone that has been on injections, has responded well, but needs frequent injections in order to maintain that vision.
Yeah, and my understanding is that in the clinical trial that the participants had to have received 3 injections of Lucentis already and shown positive response. So to your point, to be known to at least have some benefit from the injection before it's given in a more long-term format. So you mentioned the refills. So any comments on how often refills should be needing and what that will entail? Sure.
Yeah, and an additional comment on that too is basically what the FDA label and what the indication is currently is this product is indicated for someone that has responded to 2 anti-VEGF injections. So that could be, has had good responses to either 2 injections of Lucentis, 2 injections of Eylea, 2 injections of Beovu, 2 injections of Avastin. So any patient that had a good response or adequate response to any of those anti-VEGF treatments is a candidate potentially. And so that's on the labels. That's really important to remember. The other thing is the refills, as you mentioned in your question, the refills are indicated for every 24 weeks. So essentially every 6 months is indicated for a refill, not sooner, not later, every 6 months. So approximately every 24 weeks, that's when the refills are indicated. Now, the surgical procedure itself is done in the operating room, whereas the refill portion is done in the office.
Yeah, and my understanding again is that the refill is a very similar procedure to getting an injection, except for instead of the needle going into the eye through the eye wall, it's actually just going into the small port and refilling it.
That's correct. So it's not only refilling it with new medication, but it's also extracting any old medication out of that port, out of the same device. So the vast majority of the after refill, it's going to be all new medication.
So a question that we got in was, is age a factor for candidacy? And I think that probably the best answer for that is that, as we know, age-related macular degeneration is an age-related disease. And I do not believe that the FDA has made any limitations as far as patient age. So regardless of whether you get AMD when you're 65 or if you get it when you're 85, you could potentially be a candidate for this treatment.
Yeah, and I will say this, again, this is all my personal opinions and things like that. But as a surgeon, I think that, again, you got to take the whole patient into consideration. So yeah, age is definitely not a restriction by any means, but you want to make sure you have a good surgical candidate. So I'm, making sure they're relatively in good health, things like that. So again, but I don't think age, like I don't see why we couldn't implant this into a 100-year-old person. I don't see any contraindication, to that. But at the same time, I think it is a factor.
So, a big question on my mind, and one that I've already started discussing with my local retina specialist, is, will this be covered by insurance?
So yeah, I think that, obviously we are kind of in the early stages of that. I think it will be. Again, I think it all depends on your region and area, what insurance plan we're talking about, and so forth. Whenever you get any sort of new device or new treatment or new drug, anything, it's usually in the beginning, first few months, it's always a kind of a process to develop with your billing and coding teams and things like that to get these things properly authorized and properly reimbursed. I would say that, Genentech is a great company to work with. They have staff that are dedicated to facilitating this. So I think that from a doctor side and a patient side, I think that's probably not really a concern, because again, the company and manufacturer itself, Genentech, is really good about helping to support patients and doctors regarding this.
Yeah, and the other part of that is that besides just, there's both the drug part of it and the device, and so surgery centers need to be involved in that, figuring out the insurance and payment part also. So I think, unfortunately, it's not a super easy question to answer anytime it comes to insurance. So we got a couple more questions in the Q&A, so I want to go ahead and go through that. So one of the questions is, I've been receiving injections for 6 years now, and I hate getting them as they hurt. Would I qualify for Susvimo? And so, kind of like what Dr. Malley mentioned, if you're someone that's been getting injections and have responded well to injections, then that would seem like someone that would be potentially a good candidate for Susvimo. So I think that's definitely something that is worth asking your retina specialist about. Which I think then brings in another question that I had prepared is this something that all retina specialists will be doing, and what's involved in the implanting of the actual device?
Yeah, great question. So, I think that obviously not all retina specialists do every procedure. So certainly, especially with a new procedure, new technique, new device, there's sort of a kind of a rollout or a launch kind of organized launch system. So it's not just like everybody does it at once and that's it. This requires usually surgical training, additional counsel by the company to sort of go in, kind of discuss, educate physicians on it first, and then it's kind of rolled out in a very controlled fashion. So that's what they're currently at right now is kind of starting that process potentially of starting to train additional surgeons to perform this technique and implant the medical device. But so that hopefully helps answer that part of it.
Yeah. So I think it's something that it won't be in the next few weeks that people really start getting this. My suspicion is that it will be, next year sometime, January, February, before this starts getting implanted with any regularity, both because of the training needed, along with all of the insurance issues that need to be cleared up before that starts happening. And then what about the actual procedure? You mentioned it's in the operating room. Is it safe? Is there anything else you can say about the actual surgical procedure?
Sure. Yeah. I mean, it's a very simplistic surgical procedure, relatively speaking. So very easy to implant. It's an outpatient surgery, so it means you don't have to stay in the hospital or anything else. It's usually done either at an ambulatory surgery center, very similar to like a cataract surgery would be, or can be done in a hospital setting, in an outpatient surgical center in a hospital. So it's kind of in and out procedure. You don't have to stay in the hospital or anything like that. Again, it's an implant that is inserted on the eye wall as I mentioned, and then covered with sort of the kind of quote unquote skin layerings of the eye to kind of help cover it so it's well protected and well sealed under the wall of the eye, or on top of the wall eye. Again, it's a very seems like very straightforward procedure.
Good. All right, let me look at some more of our questions here. So actually, and so to kind of go along with that, someone's asking about what are some of the risks. And so I'll answer that very broadly, then I'll see if you have any more specific of answer. So, any surgery, really the main risk is the risk of infection. And whether it's cataract surgery, whether it's a retina surgery, whether it's surgery on your arm for that matter, infection is one of the main risks that we always worry about. And you may need to correct me on this, Dr. Malley, but I believe in the clinical trial, the infection rate was about 2%. So about 2 people per 100. And, so that may sound like a lot. It may not sound like a lot. To put in perspective of cataract surgery, the accepted rate is closer to 1 in somewhere between 5 and 10,000. So it's a bit higher than that. But what's your take on that?
Yeah, so this is the key, with any sort of clinical trial like this. Again, it's a trial. You do things one way, and then you kind of realize, okay, there's a better way of doing this during the trial. So the reason for the slightly higher infection rate than you would expect is because what they're finding early on, a key component of the surgical procedure is what we call the conjunctival closure, or means that skin layer that you're putting over the device, you have to make sure that's sealed down very, very well. And what they're finding is that was the key part that was leading to increasing rates of infection, was that those areas weren't sealed down very tight, and it was allowing the possibility of infection. So once they corrected for that, the infection rate actually was overall, after that kind of correction, was very, very reasonable, and was not kind of a higher rate. So it's just a matter of kind of fine tune the surgical technique to improve those rates. So then I think the infection rate is actually very acceptable because you're able to modify the technique to make sure that you get a good closure of the conjunctiva, which that helped to really decrease those rates significantly. So with any sort of surgical procedure or technique, it gets better over time as the trial improves. So that was the reason for that higher rate. But again, obviously, I think it's reduced dramatically with very meticulous, very nicely closed conjunctiva, which the surgeons did towards the end of the trial.
Yeah, what's interesting is that's the exact answer that I got from one of the retina specialists that I work with. And I said, is this 2% infection rate acceptable to you? And his answer was that what was learned from the study was how to really optimize the procedure, and that he thinks that in this case, the real life results as far as infections will be far lower than what there was, especially earlier on in the study. So that 2% number is a little falsely high. Because I think and that's why I wanted to ask the question, because I think that's going to be the major sticking point why some doctors may not do it, is that they see that number and say, well, that's a really high rate of infection, where to your point, yeah, but once you learned how to do it the right way, then that rate went down dramatically. It was actually the same thing with injections. When people first started doing intravitreal injections, the infection rates were considerably higher than what they are today. And now it's infinitesimally small. And so as you learn how to do things, the potential complications become far less frequent.
Another thing I would add is that once it gets rolled out commercially, more widely available, we'll have the data, we call post-marketing data, where we're able to see how the device performs in the real world, and then we'll be able to see really I'm assuming probably a much better rate and much lower rate of infection. So I think when we see that in the real world, that data will come out to show actually that there's actually an extremely low risk of infection. Now, the other thing I'll add, and a similar thing, is that a similar, almost identical situation where in the beginning of the trial, they were noticing patients were developing bleeding, what we call vitreous hemorrhage, or bleeding in the gel. And they modified the technique to add laser to help kind of prevent the bleeding And that just really drastically reduced that risk to very, very minimal rates. So again, it's just a matter of, you learn stuff during the trial, during clinical trial. And that's why you do clinical trials, because you're able to fine tune your technique. And once it reaches the public, you have a really well-established, safe, reliable surgical technique and medical device to give the masses.
So a question came in to ask if you can feel the implant. Once it's in your eye, will you know that it's there?
I mean, again, we've been implanting similar devices for glaucoma. I guess I'll say, there's like little implants that are, again, not exact same, obviously, but a similar implant for glaucoma called the Ahmed valve tube shunt, which again, I've seen those patients in the clinic, and they don't report feeling that sort of device. So I expect that this won't really be felt, quote unquote felt. I mean, you obviously know it's there because you've had surgery, and you know it's there, but it's not going to be one of those things where I believe you, because we sort of implant it in an area where it's covered by the eyelid, so it's really it's not felt by the patients, and for that reason, because it's well covered by the skin of the eye, basically, and by the eyelid. So I would say it'd be very unusual for a patient to actually feel the device.
So another question is, will I need to get refills forever?
That's a good question. I mean, we have, I believe almost 4-year data out on this device currently. Do patients need continued refills? I think it's just basically how their AMD responds. I mean, every patient is different. Every patient, responds differently to different treatments. It's impossible to tell. I mean, you kind of can see, how your vision is doing, and at some point, and you and your doctor can make that decision at some points. I don't think there's any hard or fast answer, right or wrong on that. I think it really just depends on your disease, and if it's inactive, I mean, one could consider that, but I think it really depends on your individual situation on if you need treatment and how long you need it for.
Yeah. So, and we kind of already answered this one, but because it was asked, I want to touch on it. I've just been diagnosed with wet macular degeneration. Can I have this instead of injections? And really the answer is that you'll need to get injections first to make sure that you respond. And then once it's known that you respond, then you could potentially be eligible to receive a Susvimo implant. And then, if I get it in one eye, how does it affect my other eye? And really the answer for that, like most things, is it essentially has no effect on the other eye. So when the implant goes in one eye, it's to treat that eye. And then your fellow or other eye is still independent. It's on its own. Actually, a really good kind of timely question. One of the questions is, can I continue to participate in sports? For example, pickleball. It's an important one because now pickleball is so important. And so I'll give you my take, and then I want to hear what Dr. Malley has to say. I think in any type of sport, like pickleball, or it would be even more important in racquetball, it's important to wear eye protection. And it's not a good idea for anybody to get hit in the eye with a pickleball, a racquetball, or even a football for that matter. And so I think so it brings up a broader question, just the idea of eye safety is important, whether you've had this particular implant or not. Now, I'm certain that that's not something that was checked in the clinical trial, that they didn't try to expose people to trauma to see what would happen. So I'm sure that the official answer is we don't know, because it's not something that's actually been tried. But Dr. Malley, I'd be interested in your take on, how much more susceptible might the eye be, if at all, to traumatic injuries?
Yeah, so certainly, eye trauma is real. I've actually seen some pickleball injuries here, and they've been, pretty significant. So I certainly echo what you're saying, Dr. Gerson. I agree. I think eye protection is so critical, especially in these kind of sports like pickleball or anywhere where there's a chance that a projectile can hit your eye. I think it's just so critical to wear, and with or without this sort of procedure or any sort of surgery. So absolutely, I think it's just one of those things where you have to kind of weigh out the risks and benefits and be safe. And certainly I think the goal of the implant is to ensure that you try to live your life the best you can. And I think that's what it hopefully accomplishes. But again, I think it really depends on the patient making the right decisions, just kind of common sense decisions in regards to eye safety. And, that's the key.
Yeah. So a couple questions that I'll combine into one. How will you know if your eye will tolerate it, and can it be rejected? Which is an interesting question, right? Because we think of if you get a liver transplant or something like that, that it can be rejected. But lenses for cataract surgery are never rejected, and because of the materials that they're made out of. And so really the likelihood of rejection of the actual device, I would think, is incredibly, incredibly small. But how will you know if your eye will tolerate it? I think the answer is, well, the reality is that you won't. The assumption is because it was well tolerated by the vast majority of people in the clinical trial, that your eye will also be able to tolerate it. But like so many other things, nothing in medicine is an absolute guarantee. So that's why it's important to kind of screen people and make sure that people, have done well with injections and that are thought to be ideal candidates before it's done. And that's why it won't be, the automatic treatment for everybody. I don't know if you have a different take on those questions.
No, I agree. I agree with everything you just said.
So another question that I got was about home monitoring. So we've talked on a number of our webinars about the importance of home monitoring, particularly in dry AMD and the use of the 4C home, which is actually something that Larry's talked about many times, that he's used the 4C home. But what's important to note is that the 4C home is used for monitoring dry macular degeneration, and that is the main purpose for it. I think in the future, the same company that makes 4C home will have a device that's specifically for monitoring wet macular degeneration. And so I think that whether it's the new potential device or just monitoring your vision in general, I do think it's important to continue monitoring your vision, even once you get the port, once you get the Susvimo. Susvimo does not make your macular degeneration go away. What it does is it treats the problem that macular degeneration creates. And although about 98% of people were able to go the full 6 months without any intervention or without any new leakage, that means that there are some people, although rare, that have issues in between the 6 months. So I would say that I think it's important to continue to monitor, just because not everybody responds the exact same. Not everybody has a perfect outcome from this. Can you have a port in both eyes? Is the next question.
Sure. Yeah, I don't see why not. I mean,
Yeah.
it's certainly not contraindicated. And I mean, if you have wet AMD in both eyes and you meet the criteria, you've responded to anti-VEGF injections in the past in both eyes, then, I don't see why it couldn't be in both eyes. I think that's probably going to happen.
Yeah. Excuse me. Dr. Malley, have you started implanting yet, or is this something that you're looking to start doing in the near future?
Yeah. So currently, it's been rolled out to the surgeons that were involved in the clinical trial. So it was only a small number initially a small number of surgeons that were actually involved in the clinical trial, and they've been the ones that are initially implanting it. I hopefully will be, be learning about, training on it soon and being able to implant in my patients very, very soon. So again, it's kind of a very controlled, very organized rollout on purpose in order to help to make sure that it kind of gets, to the right, people, at the right times.
Yeah. Excuse me. Do you know, once you get the Susvimo, how long does it take for your eye to start to respond? And how does the device know how or when to release the medication?
Yeah, this is all the proprietary technology that it has. I mean, that's the reason why, it takes time to, design these things, innovate these things. The port is very elegantly designed to properly allow, diffusion of the medication into the eye at the proper amounts. That's why the concentration of the ranibizumab is a certain concentration because of that. It just all fits together very, very beautifully. So it's just, it took time. It took clinical trials. It took, scientific investigation and engineering to design the delivery system to do that. And it's just our amazing ability to apply our scientific knowledge to medicine and deliver a device like this.
Yeah, I think what I would add to the answer of that is that, excuse me, if someone's receiving the Susvimo, if they've already been identified as someone that responds well to treatment, ideally when it's implanted, they're already doing well. And so that if they're already doing well from treatment, then there's really no benefit to notice, because hopefully you're seeing fairly well even before you get the Susvimo. So even if it takes a few days or weeks to really build up enough concentration to have its effect, if you're already doing well, that's just fine. And it's just kind of like you said, it just very slowly percolates out. And with, just with really incredible new technology, both in the actual drug, along with the actual device and how I do that and how you do this. So a question, how can I find a surgeon to ask about having this done?
Yeah, that's a good question. Again, as I mentioned, really, they've only released it to the surgeons that were involved in the clinical trial itself. But as I mentioned, in the near, next few months, most likely, they'll be slowly rolling it out to other surgeons. So I think just probably asking your eye care professional, about it and for updates on, when, if they're going to be an eventual implanter of the device or eventual surgeon for the device. Yeah, you just have to ask your eye doctor.
Yeah. I think something that, is real is that when patients come and ask me about something, then I'll oftentimes take greater notice or interest of it. For example, there's a new medication that came out for something totally different that I hadn't prescribed yet, but I got an email from a patient today saying, can I have a prescription for this? And so that'll be the first prescription that I write for it. But the reason I bring that up is because some retina specialists may not think that this is relevant to their patients or important, but by you asking, then that shows the interest. And so not that will, push someone to make their decision whether they use this or not as a surgeon, but at least to be aware that, if I'm getting interest from my patients, maybe this is something that, like Dr. Malley, I want to get trained on sooner rather than later versus waiting 6 months or a year or whatever the time frame could be. So, and I think it's interesting that a lot of our answers may seem like we're not giving the full answer or we're kind of skirting around it. But the reality is, with something that's so new like this and so dramatically different than anything that has been, that it's hard to know a lot of these answers. And to the point that you made, that the post-approval studies. So, drugs go through certain clinical trials to get their approval. And then once they get their approval, they're still continue to be studied so that we learn more. And I think that those will be really important in this case to really start to flesh out some of these details of what people can really expect in the short term as well as in the long term. Let's see. So projected visual outcomes. I think that's something that we should touch on because, ultimately that's probably the most important to everyone on this webinar is, well, geez, if I do get something like this, what do I expect from a visual perspective?
Sure. Yeah. It really honestly depends on your individual circumstance. As you mentioned, patients that have been on medication, injections for a long time, that have stable vision, but again, require frequent injections. Again, this device has been shown to maintain that vision or again, improve vision just as much as a monthly injection would of Lucentis or ranibizumab. So really in regards to the visual acuity, whether it's maintenance or gains, you really have to compare to what you would do on monthly ranibizumab or Lucentis to really know, what would that really be. So I would just say that it's the goal of this treatment is to deliver, very similar visual gains or maintenance of gains as monthly ranibizumab.
Yeah, and the other thing that I would point out is, and again, we've talked about this on numerous other the webinars we've done together, is the earlier you catch wet AMD, the better off someone is going to be, the better they'll do. And so when we've specifically talked about using 4C Home in the past as a way to be able to pick up change very early. So I think we would both advocate for appropriate patients using 4C Home, along with having regular visits to your eye care provider and not waiting for there to be a problem before you say, oh, maybe I ought to go and get this checked out. So regular visits as prescribed by your provider, and home monitoring. And again, in particular, what we've talked about is 4C Home to catch something really, really early. And I think that's the best way to at least have the potential of having a really good outcome. So I think that you would probably agree that Susvimo won't be the end all be all, and that some people will in fact get this, and there will be other patients as well as doctors that do not feel that this is for them. And so I think there will continue to be the need for injections. And so I quickly wanted to bring up, this is unrelated, but by the same company, so I think it makes it related, other new drugs that are coming. So did you want to comment on any of the pipeline, any of the new drugs that will be coming down the road that may also be an improvement compared to what's being used now?
Sure, absolutely. Yeah, I think one in particular is faricimab, which is also made by the same company that makes Susvimo, which is Genentech. Is showing a lot of promise. It just got recently. It's hopefully going to be. It just got recently submitted for kind of analysis by the FDA for possible approval. It's showing a lot of promise as a potential 16-week dosing agent, which means that potentially could be given up to 16 weeks and maintain a patient's vision with wet AMD, which again currently we only have up to about 12 weeks with other with like BOV, for example, or Eylea, or other agents like Lucentis. So this would be a nice sort of additional durability benefit. And the mechanism of actions are also a little bit different too, in the sense of it's both what we call an anti-VEGF and what we call an Ang2 inhibitor, which is what we find is maybe very important in development of new blood vessels. So like the blood vessels seen in wet AMD. So I think the fact of having a different mechanism of action, having 16-week potential dosing, and maintaining our robust visual gains that we see with other agents is really going to be a nice leap forward with faricimab. And I suspect it will get approved in the near future, and that'll be great. I think that'll be great timing, because we'll have patients that will benefit from Susvimo as an implant device, and then we'll have patients that may opt for injections and could go on this 16-week injection interval agent called faricimab. So I think these two products could potentially cover the vast majority of our wet AMD patients. I think this combined, those two agents would probably be great options for probably 99% or more of our wet AMD patients. So I think that's really exciting to have both those innovations around the same time. Hopefully, Susvimo is FDA approved. Faricimab is closely, not too far behind in approval. And I think having both of them at the same time is just going to give our patients great options for longer lasting agents and really incredible durability gains.
Yeah. So has the port been tested using Avastin? So at this point, it has only been tested using the highly concentrated ranibizumab or Lucentis. And the way that it's refilled is with a very special device, a very special cannula. And so it's not like a doctor can just say, well, I'm going to take Avastin and put it in and see if it works. So at this point, it has not been tested with any drug or any different concentration of any other drug. And my suspicion is that really it won't be, because taking the chance of injecting a different medication, not using the approved or correct method of injecting, seems like the risk there would be quite high. So the other question that we have right now is Susvimo only for eyes that need injections every 4 weeks, or for any time in between? I have one eye needing every 4 weeks and one eye needing every 8 weeks.
Yeah, certainly. And that's kind of where the strategy is. I think, for me, I can say when an ideal patient, that 4 to 8 week mark, to me makes a lot of sense. I mean, you're saving a patient a tremendous number of injections per year with, potential six month dosing versus, 4 week or 6 week or 8 week dosing. So yeah, for me, I think theoretically, both eyes that they mentioned, the 4 week and the 8 week, would fall into great candidate range for Susvimo. So I think it really, again, that's a discussion with your doctor. But again, for me, at least personally, I think that 4 to 8 week interval is a nice sweet spot for a really, really easy, good slam dunk candidate to do this device in.
Yeah. So I will say at this point, we don't have any other questions that have been sent in. So if anyone does have any last minute questions they'd like to send in, please feel free to send that. Hopefully what we've been able to do is really just continue to foster the mission of the Macular Degeneration Association of providing information and education so that you can be armed with it. So the next time that you go to your eye care provider, this could be potentially something that you bring up as a point of conversation, as something that you may have interest in for yourself or somebody else. And even if it's not quite available yet at your next visit, well, maybe the one after that. As Dr. Malley was saying, that this is the plan is for a fairly well-controlled rollout. It won't be all retina specialists will be able to do this tomorrow. It'll take a little bit of time. So I think that's a really important thing, that as anxious as somebody may be to go ahead and get this done, that it may take a little bit of time before you get this done. So, we do want you to realize that, but, we really hope that the people that are on today have been able to take something away from this and learn something about this. One of the things that I'll also point out about Macular Degeneration Association is that on our website, macularhope.org, there's a blog where we oftentimes post articles or blog posts about just anything new, about new stuff in the world of macular degeneration. I think we recently put one up about how cataract surgery may or may not affect macular degeneration, when there's been things about new drugs, whether it's been approvals or clinical trial results, we post that stuff. So even though we don't do these webinars, every month, or at least the two of us don't, we've been doing a tremendous amount of webinars over the last 12 months. And we'll continue. The plan is to continue doing some virtually like this. There's still all the blog posts where there's great information. So keep coming back to macularhope.org for more and new information. So no other questions came in. So I just want to say thank you both to everyone for logging in, and also to Dr. Malley for having this conversation. I'll leave the closing words to him.
I just want to ask one question.
Sure.
Medicare responded at all on whether they'll pay for it, and if so, how much? Not insurance, just Medicare. Do we know?
I don't have an answer to that question. What I can tell you from the retina specialists that I've been in communication with here, they're waiting to hear from their surgery center what Medicare is going to pay. And so, or regular insurance. So they haven't gotten guidance from Medicare or the commercial insurance carriers on payments yet. And that's right now their big holdup, because they had someone that was part of the trial doing it. But right now that's their holdup to starting to do any of these, is they don't have any clear guidance on payment for it.
Well, how if you're not going to get paid, nobody's going to prescribe it.
Yeah, right. Unfortunately, that's a really important point. And that's another part of the picture, is that,
If there was private pay, do we know how much that is?
I don't know the answer to that. Dr. Malley, do you have a sense of that?
Rolling this thing out.
Yeah, I think it's going to take some time. I think we're still in the very early stages, and any new device, it does take time to get the proper coding and the proper, system for reimbursement. So I'd say, probably over the next 3 or 4 months, we'll probably have most of those things worked out. But just kind of stay tuned. I think it's just a matter of just, kind of watching it patiently and seeing kind of how it rolls out. But I suspect my personal opinion, I think it'll be covered. I think it'll be, covered by Medicare. I think, all that will be all squared away, but it just will take time. It'll just take some time.
The other thing that I'll mention with that is Genentech historically, for their drug Lucentis, has had really good patient assistance programs. And so whether it be Genentech or Regeneron or Novartis for that matter, for their anti-VEGF, for their injectable medications, They all have really good patient assistance for people, whether you have insurance or not. And really their goal is to make these treatments as affordable as possible, as often as possible. So obviously, Larry, it's an issue, but it's one that even the manufacturers, they have a vested interest in trying to make it less of an issue. And by the way, I should note that this has been recorded so that if anybody missed the beginning or any part of this, I guess, or if you want to have, if you enjoyed it and want to have one of your friends or someone else watch it, it has been recorded and will be posted on the Macular Degeneration Association website, macularhope.org.
Very interesting. Thank you, guys. And stay tuned for our next webinar. Have a good day and a good weekend, everybody.